Good afternoon, everyone. Stephanie Winters from the Vermont Medical Society. We're just giving people a moment to join in and then we will get started. Great. Good afternoon, everyone. This is Stephanie Winters from the Vermont Medical Society. I'm welcoming you today to our, I've lost track of the number that we've done so far, but to our next webinar in a series of refugee health webinars that we've been doing. And today we're talking about working with interpreters. And I just have a few disclosure slides for CME to go through, and then I'll introduce our wonderful panelists. So this is approved for CME and social work credits. So Bertie Polly, the VMS program and event coordinator, is on with us, and she will be sending out an email to everyone who's joined us to tell you how to collect your CE or CME, and that needs to be done within 30 days. There are no disclosures, no financial disclosures. We didn't accept money, and our speakers have no financial disclosures. And then this is just a little snapshot of our website. Last week we had a talk on tuberculosis. This week is interpreter services, and then we have 3 more in our series coming up. And so if you go to vtmd.org, refugee-health, that will come up with the series, how to register, and also past recordings and lots of resources. And all of this is thanks to Dr. Andrea Green, who's really spearheaded this webinar series and all of the resources. So now I'm happy to be able to introduce our speakers for today. We have Cathy Kelley, who's the social work care coordinator for the Pediatric New American Program at UVMMC Pediatric Primary Care. We have Mohini Joshi, who's the lead Nepali interpreter at the University of Vermont Medical Center. And we have Stan Weinberger, who is the medical director of the Pediatric Primary Care at UVMMC and a primary care pediatrician who treats patients in the pediatric immigrant clinic. So thank you all for joining us, and I'm going to pass it over to Cathy, who's going to start the presentation.
Good morning, everyone. I'm really glad that you could join us today, and we're going to really encourage you to put any questions you may have in the chat as we go along, and hopefully we leave time to get to those at the end. Next. So this is our agenda for today. We're going to go over some interpretation basics. We're going to talk about the importance of providing language access and some tips for working effectively with interpreters. For those of you who are new to working with interpreters, we really hope that there's some helpful content here. And then for those of you who might have experience working with interpreters, we really hope you get some validation for what you're doing and maybe learn some new things. Next. So this is a pretty extreme example of working with someone whose first language is not English. And so we really don't encourage this behavior. What we would like to have you focus on is a framework that I'm calling the 3 R's, which stands for readiness, rules, and respect. Next. So under the heading of readiness, how can you be prepared for working with limited English proficient patients, clients, family members? In general, everyone should be thinking about how they can best ensure effective communication. And we all struggle with this on occasion, especially when we have really busy schedules, maybe patients stacked up, lots of other things on our minds. But these are just some things that are really important to think about. And so we want to simplify whenever we can, provide a clear and concise message. We want to allow for mutual sharing. And when we're working with interpreters, sometimes we forget to allow for what I call the full cycle of communication. So we put a message out, it goes through the interpreter to our patient, the patient responds, comes back through the interpreter. Sometimes we get impatient, or we're very focused on what we want to say, and we don't wait to hear back from the patient. We want to check for understanding whenever we can. And just a point that nodding or some other nonverbal cues might have a different cultural meaning than we might be thinking coming from a more Western lens. We want to think about the context and the audience, think about the age of our patient, educational level, cultural context, and really try to tailor our information accordingly and clarify when needed, over and over if needed. Find other ways to get your message across. Next. So some important terms to talk about today. A very common error is that we use interpreter and translator interchangeably. They're not the same thing. You might hear this even on a TV or radio report. They might use the term translator when really what they mean is interpreter. So interpretation deals with the spoken word, translation with the written word, and they can require different skill sets, different types of training. We use the term LEP quite a bit, limited English proficient or proficiency. And then a really important concept that we want to get across today is language or linguistic access. And this is really an essential component of cultural sensitivity or competence. Next. So when thinking about readiness, we also want to really be thinking about the impact of language barriers. And just to say, that's a shared problem. So that's not just an issue for our limited English proficient patient. That's a problem that we also have. We don't speak their language. We are not set up to meet their needs linguistically. So when we are not addressing the language barrier, outcomes can be really poor communication, lack of connection or engagement with the patient, unproductive or even harmful discussions. And in health and mental health care, there could be many negative consequences, even life-threatening consequences. Next. When we think about readiness, it's important to understand that there are legal mandates which underpin the right to language access. So language access is a legal issue as well as a practical and ethical issue. Language access really is a human right. And so this has been reinforced through different legal mandates and is covered under the ADA and the Affordable Care Act. So this is something that really, again, has that legal underpinning, but it could be a little vague. There's an emphasis on reasonable steps and meaningful access, which can provide a little wiggle room. And I do spend a lot of time pushing back on providers who are not providing language access and reminding them that if they accept federal dollars, that they really need to do that. Next. So logistics, of course, are really important when we think about readiness for working with our limited English proficient patients. So to start with, you really want to be familiar with your institution's protocols. How do you access an interpreter? What are the options available to you? Can you have an in-person interpreter, or do you need to use a video or phone interpreter? How do you set that up? What is the equipment that you might need? And when do you set that up? So there are different advantages and disadvantages to those different formats. And for in-person interpreters, we find that that is the most personal or intimate way of communicating with our limited English proficient patients. It allows for more nuance and detail. The interpreter has access to all the nonverbal communication that's going on. They have a better sense of setting and context. The phone, getting a phone interpreter could be pretty quick and easy, although not with some languages. And it can be more useful for quicker contacts, like phone reminders about appointments, or I actually spend a lot of time on the phone and sometimes even do like a 4-way call where I have the interpreter on the line, a patient or a parent, and someone from economic services or Social Security or another provider. So it could get quite complicated, but that might be the only way to have that communication. And with phone and video interpretation, it might feel a little more neutral with fewer conflicts of interest. Some of our refugee communities are fairly small and people might know each other. And also, we do find that the video interpreters especially are very formally trained, and usually things go very smoothly with them, which is not to say that our in-person interpreters do not have that same training. And this is my opportunity to say that Mohini is someone we've worked with quite a bit and is very well trained. And it's so helpful to have someone with that kind of training and appropriate boundaries who is serving as our interpreter. Next. So I'm going to give this over to Dr. Weinberger, who's going to talk about considerations for Afghan patients.
Yeah, thanks. We wanted to spend a little time touching on this, and as a couple caveats. One, kind of the general rules that we're talking about in terms of using interpreters effectively really apply to all cultural and language groups. We'll talk a little bit about some specific cultural considerations with Afghan patients, but realizing that, again, also our patients and families are individuals. And so they're not necessarily defined by their cultural group, but also you will find, many of our folks that we work with from different parts of the world, may also share similar concerns as these. So, good to keep that in mind. But we do find that particularly with our Afghan patients, interpretation can be challenging to find. Our two primary languages are Dari and Pashto. and there is not a lot of in-person interpreters there. The other thing, and this is, as we talked about with in-person in general, these are small communities, and so there can be confidentiality concerns as the family may know the interpreter outside of the healthcare setting. And so that, just as a reminder, we don't rely on family members for interpretation. There is a great talk by Tracy Dolan, who's our director of state refugee of the State Refugee Office here, and Andrea Green around some of the cultural considerations. But right, some of the things they talked about are that men and women have really defined roles in Afghan culture. And so oftentimes in the healthcare setting, people will prefer to work with same gender healthcare professionals, and that you could extend that to interpreters. And particularly as the things that you're talking about become more sensitive, like particularly if you're talking about reproductive or sexual health or genital urinary issues, that would be a time to really, if possible, match same gender providers. Also, don't assume that all patients or family members are literate in their spoken language. And oftentimes you get family members where there'll be variable proficiency in English or variable ability to read or write in their primary language. The last thing I would just point out too is that, and they pointed this out in their talk, that women may defer to their husbands to give history and answer questions as part of those gender roles. And that can be really challenging if you're trying to get information, if the female is your patient or the mother who may have particular information. And so navigating that can be something that's a challenge, but something to consider, not just with our Afghan patients, but with some of our other groups as well. I think we can go on to the next slide.
Thanks, Dan. So now we're going to talk about rules a little bit. And of course, these are not hard and fast, they're more guidelines. But just a reminder that we always want to speak directly to the client or patient and not to the interpreter. So we want to use first person. We want to say, how are you feeling today? As opposed to, can you ask her how she is feeling today? We want to always be making eye contact with the client or patient, which is not to say we should never look at the interpreter, but the patient is our focus. We want to speak clearly and at a normal rate, break up complicated statements and questions, really be mindful of our slang and technical jargon. And then in any meetings, we hold a lot of care conferences where we have the family, perhaps the patient, the medical team, the school team, other community providers, and an interpreter. We want to be really mindful of the interpreter and not have side conversations. We want to make sure everything is interpreted for the family. And again, just a reminder about waiting for the patient's response. We want to allow for the full communication cycle. Next. So some best practices to consider when working with interpreters in a healthcare setting. We always want to use trained interpreters. So as Stan said, we don't want to use family members. We don't want to use children of our patients. We don't want to grab someone from staff who might be multilingual but has not been trained as an interpreter. We want to think about establishing ground rules, defining roles, discussing the time frame and goals of our meeting, explaining any paperwork that comes up. And this is especially relevant when we're having any kind of larger meeting, like a care conference. We want to address confidentiality. When someone else is in the room, I think we can all relate to how daunting that might feel. Someone else is hearing some perhaps very personal information about you. So we want to make sure that our patients, but also our interpreters, understand the parameters of confidentiality and the consequences for not maintaining that. When possible, we want to allow for pre and post discussions. So when we're bringing an interpreter into a meeting or visit, we want to give them some context. That doesn't mean we have to explain everything that's going on to them, but especially when there's a more complicated visit, you might want to say, this is who is in the room, especially for a phone interpreter who can't see that. And, this is how long we'll be meeting. And, please ask questions if anything is not clear. You want to provide training on any assessment measures that you're using. If you step back and think about it, if you hand a complicated assessment or questionnaire to an interpreter and they've never seen that before, that might be very challenging for them to figure out how to interpret to the patient. And when possible, especially with more complex patients, you want to think about building a consistent provider interpreter team, and even possibly having the same interpreter for all of the providers that that patient sees. Next. So some rules or guidelines for interpreters. We want to make sure that interpreters are interpreting all information as thoroughly as possible. So they're not leaving things out, they're not substituting, they're not adding in their personal perspective. They're really focused on communicating the client's words as closely as possible, even if these don't answer the question that we asked or don't make sense to the interpreter. That's important information for us to have. They should stay within the boundaries of their role. They should clarify when needed. And a very formal way to do that is to say something like, as the interpreter, I would like to point out. This could be very helpful when the interpreter is acting as a cultural broker, which we'll talk about in just a minute. And then again, maintaining confidentiality. Next. So these are interpreter roles that are accepted within the healthcare field, but also other fields that interpreters work in. So the conduit is the interpreter who interprets everything, no additions or subtractions. There's no personal voice. The clarifier adds a little bit to that. So instead of just allowing information to kind of go through them without changing that in any way, if something is not clear, they want to ensure there are no misunderstandings, and they might speak up and again say, as the interpreter, I would like to clarify what you mean by this certain term. The cultural broker takes that a step further to add information about cultural differences. But again, while maintaining those professional boundaries. And the advocate takes on an even more active role to ensure that clients' needs are met. This might involve more subjectivity. The interpreter is making a personal assessment about what that client or patient may need. So the roles that we would like interpreters to take on in our setting would really be of a clarifier or a cultural broker. To take on an advocacy role could take away from really focusing on communication and information sharing. So we would prefer for interpreters to really, stay within the clarifier and cultural broker roles. Next. And I want to finish by focusing on the last R, which is respect. And, we really want to build strong relationships with our interpreters. We also want to respect the position that our limited English proficient patients are in. So by really focusing on language access, we are respecting all members of a given meeting or visit. We're communicating as clearly as we can, and we're providing mutual feedback as we go along and really building that relationship. And it's really important to pay attention to the impact of this role on interpreters, especially in the mental health field. Interpreters can be subjected to some really difficult content, really difficult experiences, and they often don't have someone to process that with, to really share what they went through and get some support around that. So I just ask you all to be mindful of that and to remember that we can't communicate effectively with our limited English proficient patients without our interpreter partners. So that's my segue to Mohini, who is going to cover the next slide.
Thank you, Cathy. Hi, everyone. I have some of the very basic tips or like advices for my providers. So these are very basic tips, but it will make my job a lot easier if some of these are followed. So like the first point is setting the stage, setting the stage in an appointment when interpreter comes in or when they are about to enter a room will be better. Like this point came in when we were discussing about this presentation with Dr. Weinberger, and he mentioned like if whenever he goes into an appointment where he is using iPad as an iPad or VRI for an interpreter, he tells like this is so and so's appointment, and this is what we are talking about. After that discussion, a couple of things came to my mind that day, and like it's not only during the like VRI setting. Like I realized later, like during like end of life communication, and whenever we are having a complex medical need, interpreting at that time too, if we are briefed a little before we head into that room, then that things make a lot of difference. Also, like the community whom we serve, they are so used to our face, like they kind of assume us to be the bearer of the bad news, and that happens all the time. So another thing is like for complex medical patient, and especially for mental health sessions, if we can count on the same interpreter, then that'll be very beneficial. It's not only for the provider, but I would say it's very important for the patient too, because if they have the consistency of same interpreter, then they can open up very easily, and then they can share the things which they will not be sharing if they are having like interpreter, different interpreter in like every setting. So another thing is like the clarification. We do know whenever we are in a session, when patients are answering or the client is answering the question, we do know when the clarification is needed. Like, for example, if someone comes, says like, I have a rash or I have a tingling, especially with pain terminologies, if we if we don't, or like if the providers don't clarify it, then we are going to end up with a wrong diagnosis. That is very, very important. And then one thing that I really want providers to keep in mind is like, whenever you guys are working with non-English speaking patients, that appointment is going to take longer. It's going to take way longer than when like providers are spending time with English speaking patients. And if it's if that thing is in the mind, then things tends to move very smoothly. So there are a couple of things I really want providers to avoid as well. Like I have seen in many settings where providers will directly be talking to interpreters rather than speaking with patients. Like these things I see mostly with new providers, and sometimes also with the providers who have been working in the hospital for a long time. So it is very it's kind of like very disrespectful as well to patients. Sometimes after the session, when we come outside, they kind of give us the comment like, doctor was speaking with you, I'm the patient. So these things do come up. And also like, when interpreter is interpreting, it's kind of like when there is a session going on, or just like when MA comes in and then do the first intake, and once he leaves, we do wait for providers. I would say about 10 minutes, 15 minutes, sometimes longer than that too. And there has been many instances when providers just comes in and say, hi, I'm so-and-so, and I'll be doing your exam. And after that, they will start typing immediately. And at that time, patients, like they don't say anything to the provider, because for most of the patients which I work with, providers are God to them. They are second of a God. So they will never say anything to their providers. And once the appointment is done, then once they leave, they will be like, we waited for provider for so long and they didn't even have eye contact with us, and they started typing. I don't know how this appointment went. And one of the another most important thing I would like to focus on is like, especially with non-English speaking patients, but Dr. Weinberger did say it happens with English speaking patients too. It's kind of like, hi, how are you doing? So you guys came here for so-and-so checkup, correct? And then they will be like, yeah, I'm fine. I have headache, I have leg pain, this thing started this, that thing started this. And I will be interpreting exactly what the patient tells, but providers kind of feel like, okay, this is what I didn't ask, so you need to kind of stop this. So it's kind of like I mean, like, it's kind of rude to tell like that's not my job, but it's actually not my job to manage the flow of the conversation. So it will be very beneficial for me and for provider too to manage the flow of the conversation during those circumstances. Yeah, that's all I had to tell. Thank you.
Thanks. We'll talk about some cases next, but I can definitely attest to that how important it is to address the family. And I do find that families will often sometimes turn to the interpreter to answer a question, but I try to just, respond facing the patient, almost sort of agree and welcome the interpreter, but when I'm speaking to the patient, kind of ignoring them off to the side. And I will say, right, it is managing families who run on with stories or are taking visits into side directions happens regardless of the language we're using, and can be challenging regardless, but something that we need to be taking on and not our interpreters. So let's go through some scenarios, and this is a great time to throw some stuff in the chat or unmute and answer. I will say with all of these, they come up frequently, and there's not a particular one right way to handle these, but we sort of wanted to bring them up to think about when thinking about readiness or rules and respect, how we might handle them. So the first one, we have myself being in pediatrics, I'm often thinking about patients and their parents, but we have a patient or parent who speaks some English and doesn't want to use an interpreter. But I have some concerns about their understanding, and this happens often. Either, my rooming staff will come in and say they refused an interpreter. They seem fine. And, I think many families do have a level of proficiency that allows for vital signs to be taken, but actually are not really refusing. They would like an interpreter for the visit. So I always clarify and almost always have an interpreter, but also many times, families are proud of their English proficiency and do not necessarily want an interpreter. Or they might have reservations about confidentiality, or they might just not want to cause trouble, right? Feeling like, I don't want to put you up by requiring an interpreter when I am getting better with my English. And so there's a couple ways that I tend to handle that. I think it is important for families to know it's their right to have an interpreter. Also, that's easy. We do this enough that it is quite fast for me, if we haven't planned ahead or had an in-person interpreter, to get a telephone or video interpreter. I often will say, I would prefer that we have an interpreter because I want to really make sure I'm understanding all that you're telling me, and so that we can come up with the best plan. And so usually I try and put that on myself to say that it's really helpful for me. I have definitely had some times where patients really say no, 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 in which case we sort of have an agreement that I'm periodically checking their understanding, and also reminding myself, like I always try to do, to simplify and not use jargon. I don't know if Mohini or Cathy, you have run into that situation or have other things to add there.
I think it definitely comes up, and I like to frame it as my need. Like, I wish that I spoke Nepali, but I don't. And so I just really want to make sure that we're communicating as clearly as we can. Sometimes that works, sometimes not so much.
The next scenario is with an adolescent patient. Well, kind of two related scenarios. We'll talk about the adolescent, and this comes up often, that the adolescent speaks English and the parents do not, and sort of how to manage that visit. I will say Mohini brought up literacy in the spoken language. And it is true that many teens that I see, are not literate or totally proficient in their parents' primary language anymore. They may understand pretty well, but have difficulty saying, as well as, they're still building their English proficiency. And so it becomes really kind of this tricky time. It also can be tricky for interpreters, as they've got, people just answering in English and other people not answering, and sometimes, particularly if they're on a phone and can't see who all is in the room, to know what to interpret. So ideally, right, we want to have the interpreter interpret everything to the parent. So when I'm asking a teen direct questions and they're responding, that the interpreter would be filling in the parent about that conversation. Sometimes I'll summarize, and I'll sort of ask a teen a question and then I might say something like, Hussein, direct to the parent, Hussein and I were just chatting about school and how that's going. And he was, telling me blah, 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 where I might ask a couple questions and then make sure the parent understands what we were talking about. What about confidential stuff, right? So we talk about a lot of confidential information with teens. And it's important to remember that just like we would do with our English-speaking parents, right? There are subjects where I then discuss confidentiality and have the parents leave the room. And I usually then have a conversation with the teen about confidentiality and would the teen like the interpreter to stay in the room for them, and that the interpreter has the same confidentiality rules, because sometimes teens prefer that, while they may have good English proficiency, it can get challenging. It's just much easier to explain things in your primary language. And sometimes they don't want that. And frankly, it's up to them. The not being an adult doctor, although I have seen this and I know that it happens where you have, right, the equivalent would be an adult child and of an elderly parent who doesn't speak English, and and that person may very well take over the conversation and speak for the patient. And that can be challenging. And again, I think, importantly, or, I think related to that, we talked about our Afghan patients, but where you have, say, a husband or partner speaking for someone else, within the context of respecting your role and how important you are to the patient. I really want to hear from so-and-so about this particular thing. What if the adult child just wants to be the interpreter themselves? This was making me think about those roles, right? And I think, many of our patients do need advocates, right? The US healthcare system is complex and advocacy is important, and it's really hard to interpret and at the same time take in health information and be an advocate for patients. And so, I would much prefer that adult, other people in the family who are supporting the patient be there as the patient's advocate. That's actually a really important role, and it's hard for them to interpret and advocate at the same time, so that we have an interpreter and then they can focus on the patient. What if you get a sense that you're working with an interpreter and they're changing the message? I guess first, how would you know? It can be somewhat tricky to know. I mean, I think about sometimes interpreters will just seem to answer the question directly as though it came from the patient, but they clearly didn't ask it. Sometimes they'll, add side comments to sort of answer, interpret what the parent might be saying, and then add some side comments about the family or their understanding. Or sometimes it seems as though the interpreter and the family is arguing or going back and forth about different things. I will say, as a caveat, right, like some things that are quite succinct in English are longer in other languages to explain, and vice versa. So it's not always the case where you get a long conversation and then the interpreter turns to you and says, no, the answer is no. There's more to it, but the timing of it does not always translate, but that happens a lot. I know as I start to see that happen, that's often where I attempt to either give feedback to the interpreter, like, I need you to tell me what the patient said, or I can see that there was more conversation there. Could you please tell me what that was about, or try to give some feedback there. But I've had many times where I just have to say, okay, I think we're going to end this visit. Thank you, interpreter, and then get another interpreter. That's less awkward if it's a telephone or a video interpreter, because you can hang up. With an in-person interpreter, that's a challenge. It just has more awkwardness about it. I don't know, Cathy or Mohini, if you have feedback about that.
I was just thinking about a phone contact I had yesterday where the interpreter was clearly asking her own questions and kind of jumping in before I had a chance to. And it's actually someone we also use as an in-person interpreter, and I've known her for years. So it can be awkward to try to figure out how to negotiate some of those things. And that is, you know, an issue that I think I would be able to address better in person. So that's something that I will try to do in the future. But this does come up a lot. And I just want to add that for me, one kind of clue that I'm losing control of the management of the session is that my mind is drifting and I'm kind of forgetting what I asked because there's been this exchange that's gone on longer than expected. So it's important to kind of, you know, think about different clues that it might be going off the rails a little bit, and some of those could be nonverbal.
The last thing I'll say is, right, sometimes we just can't get an interpreter, and this, you know, the languages that are the most challenging are, you know, Dari, Pashto, Kirundi, and Mai in my anecdotal experience, and that's a challenge. I think that, you know, if we're not communicating, it's really not a worthwhile visit. So we often will just wait, or, you know, being in pediatrics, sometimes I'll have a child who's in school and knows some English. And so I can do an exam or get just a little bit of information from the child while we wait, so that I can then fill in the parent about what we talked about. And sometimes parents will say, you know, my child can just interpret for me. And that is really not appropriate, particularly for a child. You know, there are, and I usually explain to families, I know that so-and-so, you know, say, Mohammed, that you interpret for your parents a lot. And I have no doubt that you would do a nice job interpreting, but it is my policy that we do not use kids to interpret. And that puts you in a tough role. So we're going to wait. But sometimes we wait a while. But I always remind myself that if we leave a visit and nobody really understands what we were talking about, or there's a significant miscommunication, that's going to be worse. I realize it is time.
Yeah, no, that was great. This was a fabulous presentation. I thank you all. I think it was really eye-opening to me. One, I'm thinking we need a peer network, a peer support network for interpreters. I don't know if that's a thing, but it seems like when you were talking, Cathy, about the really heavy issues that they have to interpret and sometimes give that news, even though it's coming from someone else, I'm sure it feels like it's coming from them. So just thinking that would be a really good thing for our interpreter network. And wondering, and I know we are over time, but I was just thinking about how you guys work in sort of a system where, you have a lot of help and a lot more staff, but in some smaller offices where it's very limited. How do you even start to sort of incorporate this into your office protocol? You know, you mentioned increasing appointment times. how do you sort of think about that? Like how much time, and do you denote, how do you even go about making sure that this is, something that you can do? And I know there are a lot of resources. The Medical Society actually has sort of a collaboration with a telephone or an online interpreter service, but just thinking about the smaller offices and how you make that work.
Yeah, I would say, I mean, that is a great thing. One, get an established relationship with a telephone or video interpretation service. And that can be really helpful. And, unlike blocking in-person interpreters for a distinct amount of time, generally those are, you're paying for the time with the interpreter. And so it ends up being more economical because you can really use the interpretation when you need it and then be done. I think, like with all things, this is speaking in primary care, it does take more time to interpret. Although you build relationships with families. And so over time, that also makes things faster. And we don't always cover everything in the same visit. Just like, when I have an English speaking family and there's just much more that they have on their list to cover than we have time allotted for. And we have to table some things for the next visit. And that happens too, respecting that we need to give the time for clear communication for what we can get through, but we'll get to the rest in due time.
That's great. Thank you
And
so
you can
much.
bill for interpretation services too.
Oh,
And
absolutely.
that's important to know. So.
Absolutely. Well, thank you all. Thank you all for joining us, all of our panelists and all of our participants. This was great information, and we will be posting the recording and the presentation on the website. So certainly look back at that, or if you're watching this for the first time on a recording, thank you for joining us. And we will be back with our next webinar in a few weeks. And again, thank you all for joining us.
Thank
Bye-bye.
you. Bye-bye.
Thank you.
All right.
All right.